My name is Tom Weatherby. I'm with a group called the Venture Club. And the Venture Club is a whole bunch of people. A lot of them are retired, a lot of them are scientists, some of them are active service members, you name it, it's a very large group. We have started a program of a thing called the Synchronized National Healthcare. We started in 2006 and we think it's a pretty good system, and we want to tell you a little bit about it. First of all, we're going to have clinician teams, a doctor, a nurse, and one other person. Now, these clinician teams will be under what's called the GS system, which is a system that was defined by our great-great-grandfathers. It was good then and it's good now. The system is actually pays more for a person at a GS level working under this system than they would be making for the same job in the outside world, you know, in the civilian world. We'll call it civilian, but we're all civilians. Anyway, the point is, if I take 153 clinicians, a nurse, a doctor, and one other, and we stick them into 153 locations in the United States, and we allow them to work for 1 year, seeing 10 clients a day, whereas right now the doctors in the current system are seeing 20 to 25 people a day. But anyway, if they only see 10, we have figured out that we're going to save more than $750 million a year. And that's for 153. Can you imagine what we had if we had thousands and thousands of clinician teams? The only thing that and the reason why we're going to be saving so much money is we're going to have to change the paradigm. The paradigm in the United States is everything that we have to do is on day shift. That paradigm is crazy, it's silly. What we want to do is take facilities that the United States owns. We already own every bit of the equipment, the buildings, the parking, everything. And we're going to put our teams on in these hospitals, which are the VA hospitals, and they're going to see the patients. Now, in part one, or excuse me, phase one, it's not going to cost anything, okay? We're going to have zero cost except for the charge of the clinician teams, because everything's in place, all of the management, everything. Now, a system is paperless. We have no records on you at all. The system that we're going to use is going to have a national health database. The national health database is already created. The database was created using taxpayer money, okay, and a lot of effort has gone into it. And it's one of the best in the Western world. And it's one of the best probably in all of the world. But, you know, naturally I haven't seen all of the world, so I really can't tell, but I can tell you it's a really, really, really great database. Now this database that we're going to call National Database happens to be accessed right now remotely, meaning a doctor that's not at the location where the database is calling into it, getting the data up, processing the claim. So remote access doesn't have HIPAA issues. They have worked out everything where the system is clean, it can be accessed remotely without any issues, and all we're going to do is expand that and add our people to it. Now, phase one was about putting these doctors in these hospitals, every place that the VA has where they're seeing walk-in patients right now. We're going to have one of our clinician teams working swing shift, and the patients are going to be coming in. In phase two, we're going to merge out a little bit further, okay? And that means they're going to need access. They're going to have computers. Right now in phase 1, every place that they're seeing doctors, they already have computers. They already have everything that they need. So it's not going to cost anybody. We're just going to use the computers and the access and everything that's on site right now. Phase 2, we're going to have to start getting a little bit more control, and there'll have to be some additional computers shipped out so that you can get access to this database. Now, along with this, there's going to be one thing that needs to be created that doesn't exist right now, and it's called a scheduling and phone database. We are seeing this as one phone scheduling database per state. It's kind of like dialing 1-800 Healthcare1 for, let's say, Missouri. And as soon as you get it and the operator comes on, operator says, oh, well, I'm Medicare, I'm Medicaid, I'm Champ VA, I'm whatever, and I need to see a doctor. And what they do is they look it up on the schedule and say, okay, in your area where you're at right now, we have 3 different doctors that you can see within the following week. If you don't want to see them, it'll take you a little longer. However they work it out, they'll have the schedule up for the doctors. Now the doctors themselves at these locations will come up in the morning and they'll pick up the schedule on a computer and they'll say, oh, I've got these 10 clients today, let me look into it. So they pick out the name, they walk over to the access of the database on the health database, they bring up the information, they get ready for the client, and they're ready to go. At the end of the meeting, after you've done with the doctors might say, hey, I need you to come back in 2 weeks or 3 weeks or a month or 3 months or whatever. They put it in the schedule right then and there. Okay, here I've got an opening here, I'll put it in, bam, it's done. No paperwork, no records, absolutely nothing. Fraudulent. Right now, the United States is estimated of losing $100 billion a year in healthcare fraud. And we can get in extreme detail about how each one of these occurs. But just by the nature of our system, fraud can't occur. It can't occur. There's no kickbacks. There's nothing. There's no money exchange. There's nothing. Okay? Now, the people that are going to come to our doctors, that's kind of a toss-up right now. We originally designed this for Medicare. We designed it for Medicare because Medicare, the baby boomers are coming online in 2011 for Medicare. The very first ones of the baby boomers are going to hit the age next year, 2011. Okay? So, we have a system that for the first part is not going to cost anything to see them. What is it costing now, you might ask? Everybody on TRICARE, Champ VA, and Medicare, on the average, pays $2,455 per visit. Think about it. That is a huge, huge number, okay? Under the worst circumstances, when we finally get our doctors out in other places other than the VA, the cost will be less than $480 per visit under some of the worst case scenarios. So what we're saying is we have a system that is it was designed to pull out Medicare and put Social Security back in the black. And this is not something that's only going to be good for a year, it's going to be good forever. So the 153 clinician teams, one at each VA hospital within the United States, would save $750 million a year. Well, what is that number? Well, let's take $1 billion. If you take $1 billion and divided it by 365 days, you would get a number of $2.7 million being spent per day. So what we're doing here is telling you that in phase 1 we're going to literally save billions of dollars. In phase 2 we're going to save literally billions of dollars. In phase 3 we're going to save literally billions and billions and billions of dollars. And then in phase 4, we're going to go the other way. We're going to turn around and offer health care to every single American child within the United States. Now, the system is designed like an HMO, like the VA and other systems, in that no illegal aliens can enter the system. There's no way. There's no physical way, because there has to be documentation showing who you are, what system you're on, and so on. And so there's nobody that's going to sneak in one thing or another.